Welcome back to Diabetic Foot Files. This is Dr. G, and yet again, it is the eve of night or just wee hours in the morning. Lied to myself, said I was going to take a nap, woke up the very next morning, first thing in the morning. Like I usually wake up around 2, 3. So today in Diabetic Foot Files, we're going to talk about a term that we use in medicine called acute on chronic. So I'm sure even other diabetics, patients who had a diabetic foot ulcer has heard that term or seen it in their medical records. They'll be like acute on chronic, osteomyelitis, things like that. So, let's start with it. It didn't look that bad. That's something that some people always say. I have been guilty to say that it doesn't look that bad. I've learned to elaborate my vocabulary when it comes to that. But, we've seen it, a small plantar ulcer, dry callus edges, minimal drainage, saying that it's stable, quiet, predictable. And then all of a sudden, 48 hours, the foot is swollen. There's a smell that hits the room before the patient. Definitely, I always associate that with gas gangrene, neck fash, soft tissue necrotizing infection, or no matter what, definitely patient needs antibiotics, in my opinion, and not severe, debridement and good wound care. Okay, got to clean it up real good. I'm always excited to clean up a wound, especially if it's dirty, because it looks so beautiful afterwards. After you clean up all the necrotic tissue, like I said, it's like skin gardening. You get your weed whacker, it's aka your scalpel or whatever your choice is, curette, whatever. But I mean, depending on vascular clearance, get your Doppler, make sure they have the blood flow because if you do it without the blood flow, yeah, you need the vascular clearance because you're just causing more harm than good. And we already know that because I always say vascular. But let me keep quiet. So then suddenly, you're not just treating a wound anymore, you're trying to save the limb or the patient's life or end, okay? So, where do we get this term acute on chronic? What does it mean in our world of diabetic foot? So, acute on chronic means a sudden deterioration or a superimposed infection or inflammation on a pre existing chronic diabetic foot pathology. So, in our world, this usually means like a chronic diabetic foot ulcer that suddenly worsens, chronic osteomyelitis that becomes aggressive, a stable wound that has rapidly got infected, necrotic, or septic. And so for this chronic state, you remember we usually have neuropathy, which, you have no protective sensation, microvascular disease, low oxygen delivery. And remember, oxygen is our healing currency. That's why we need vascular to help restore our blood flow. Repetitive trauma, which is going to cause an ongoing breakdown, and the wound exists in a compensated failure state. Then how does it shift from chronic to acute? So there's a trigger when it gets shifted to acute, from chronic to acute. A trigger pushes the system over the edge. The infection explodes, the blood supply worsens, the tissue dies, and this is decompensation. So, what do we call a chronic wound? Usually, an ulcer that's more than 4 to 6 weeks old, poor healing due to neuropathy, ischemia, repetitive pressure, often secondary of biofilm, present low grade infection, and possible underlying osteomyelitis. Remember, chronic osteomyelitis is indolent, minimal systemic symptoms, usually often presents with a normal white blood cell count, but the ESR, all right, ESR, that's why it's good to do labs. ESR is usually elevated, sometimes above 100 because it is a chronic inflammatory marker, okay? So, acute, means it's a new event on top of the baseline. So acute is it's a rapid increase in pain if the sensation is intact. Honestly, like I said, patients who have really bad neuropathy, if they start feeling pain and they have an ulcer, that is not a good sign in my book. Okay. Drainage, purulent, erythema, systemic signs like fever, tachycardia, new complications like abscess, necrosis, gas, and sepsis. So when do we say in our medical records, acute on chronic? Well, you say it when there is a clear historical chronicity of the ulceration or the osteomyelitis, plus an objective signs of acute deterioration. So, example, we would say chronic plantar ulcer of 3 months, now with sudden purulent erythema, elevated CRP, acute on chronic infection with suspected osteomyelitis. See how that flows? I mean, I swear, doctors could be rappers because the way we write down perfectly, it's amazing. So, deep pathophysiology. So think of a chronic ulcer like a fragile ecosystem, pretty much is, especially for these bacteria, right? It's a great ecosystem for bacteria because they just thrive on it. They just want to weaken it more. So in our chronic ulcer, we have chronic inflammatory persistent cytokines. So what are our cytokines? The main three, in my opinion, are TNF alpha, IL-1 and IL-6. Remember that TNF alpha, IL-1 and 1-6, okay? And these keep the wound stuck in the inflammatory phase. Then our biofilm dominant. Bacteria forms the biofilm. That protects it from the antibiotics. It protects it from your immune system. It keeps the bacteria nice and controlled and quiet but not healed. Remember, it's really hard to penetrate when you have a biofilm, and that's why debridement is so important, as well as cleaning the wound. Then you have your tipping point. Something disrupts the balance, either a glucose spike, which will cause a higher immune suppression, minor trauma, which cause more of a tissue breach, a new organism introduced, or ischemic event. And this will cause an acute cascade. Now, everything is accelerated. The bacteria switches from planktonic to planktonic state, which is the aggressive state. The neutrophils flood the area, reactive oxygen species increase, the capillaries perfusion drops, and then the tissue becomes hypoxic, acidic, and necrotic, okay? And the chronic wounds don't heal, they just wait to worsen. So, most diabetic foot osteomyelitis is chronic first, okay? And then it becomes acute. So, how common is osteomyelitis? It presents in 10 to 15% of moderate infections and approximately 50% of severe infections. So this meaning is huge that severe diabetic foot infections, most of the time you should assume bone involvement until proven otherwise. Like from what is our gold standard, a bone biopsy, get an MRI if you want to see the bone marrow edema increase, but bone biopsy is the gold standard, right? So what happens if you keep osteomyelitic bone? See, that is a risk. That is a risk that patients need to be aware that they take if they don't amputate or resect the osteomyelitic bone. This is where it becomes limb salvage versus amputation decision. That's why it's good to be well-rounded and well-versed and educated about all your options. So if you're leaving osteomyelitic bone, okay, infected bone in your foot, there is going to be a persistent infection reservoir, okay? As great as IV antibiotics are, medicine is, yeah, I haven't seen them been able to flush a bone from having bacteria in it once it hits it. And remember, like I said, there are dinosaur fossils. There are fossils, okay? If you there's bones and there's fossils, but bacteria can literally eat away a bone and make it disappear from actually imaging, okay? It literally eats it. It makes it disappear. So it's not there anymore, and whatever's left, it wants to keep on eating. So when you are risking leaving infected bone in there, osteomyelitic bone, there's a persistent infection reservoir. The biofilm protects the bacteria. Remember, bacteria has a high mutation rate depending on what type of bacteria it is, and antibiotics struggle to penetrate. Then you will be at risk of recurrent acute flares. And that's what I do tell my patients, especially the ones that do have osteomyelitis, want to keep their toe, be healed it. I said, this will be chronic. Okay. Unless we resect piece of the bone that's infected, this will be chronic. Okay. And you have to keep that in mind because it'll just come overnight. Okay. It'll be just fine. And one day it's going to want to just say, hey, I want to cause a havoc. Okay. So, recurrent acute flares, acute on chronic cycles. That is a high risk, okay? That's why I said get it over and done with, like with the bone resection, as much as I love limb salvage and amputation prevention, if it's osteomyelitis, that is a high risk, okay? The spread of the infection, forgive me, soft tissue, most likely you're going to have a deep space abscess. And then remember, it's going to keep on progressing to our tendons, our joints, and the systemic. Okay. And then the amputation risk is higher. Osteomyelitis is strongly associated with limb loss. And then reinfection rates are about approximately like 27.5 reinfection rate within 12 months after treatment. Okay. So keep that in mind. So the clinical truth is chronic osteomyelitis is a smoldering fire. Acute on chronic is the gasoline poured on it. So how does the chronic osteomyelitis turn acute? So like we said, there's a bacterial shift, like a new organism introduced like MRSA or gram negative. The biofilm is disrupted. Like I said, there's a planktonic surge. Ischemia can worsen. So there's reduced perfusion and there's a greater immune failure. Mechanical breakdown, let's say a patient wants, like I said, around the Christmas time, people are on their feet a lot more. So new pressure, new trauma introduced. There's a deeper extension. And then immune system compromise. Like I said, like during Thanksgiving, people are eating much more. They can have hyperglycemia. Remember, the higher your glycemic is the glycemia, the more likely your immune function will be dysfunctional. And then systemic illness as well as abscess formation. It will convert an indolent infection to an aggressive one. Okay. And one thing I know about diabetic foot infections, they come back with vengeance. So our labs when it comes to acute versus chronic. Chronic osteomyelitis, like I said, white blood cell counts are often normal. ESR are very often very high because it's a chronic inflammatory marker. CRP mildly elevated. Acute on chronic, your white blood cell count most likely will be elevated. It may still be normal in some diabetics, but most likely it will get elevated. CRP significantly elevated, greater than 10. ESR most likely elevated, greater than 40 usually suggests osteomyelitis and like lactate. The lactate might be elevated as well. Now, we have to trend the things, okay? You don't just check labs once, you trend them. So you're going to trend the white blood cell count. You're going to trend the ESR, CRP, okay? Because ESR lags for weeks. CRP responds quite quickly. Oh my gosh. Don't you just love when you do a incision and drainage and you see the white blood cell count just drops, CRP drops, and you're just watching it trend? If it keeps on trending up, something is still there, okay? Something is still there. Don't just say, let's just see how it's going with antibiotics. If the blood cell keeps on trending, if you see the CRP keep on trending, I'm like, something's still there. Let's investigate more. Let's figure it out, okay? Don't just discharge and go home, okay? So, best combo is CRP because it helps with our acute inflammatory markers and ESR because it does our chronic burdens. So, what are our clinical signs when things change? You see a rapid increase in change, undermining, tunneling, purulent drainage, mild odor, skin can change from red to purple to black. Extreme signs are a bullae. If you see a bullae blister, admit, okay? If there's crepitus, think gas. Skin anesthesia over infected area, yeah, possible necrotizing infection. People need to know what neck fascia is. So be able to recognize neck fascia. It is a life threatening, not just limb threatening, a life threatening. Okay, because whatever part has the neck fascia, it has to be removed. Okay, regardless of anything, it has to be removed. It's a neck fascia. That part has to be removed. Okay. So, neuropathy trap. The patient might say it doesn't hurt. That's why you have to check your feet every day, monitor every day, okay? Or the patient might say it suddenly hurts. That's a warning sign for me. That's like signals like come in immediately, okay? Or go to the ER immediately. Get that checked out. Make sure everything's okay. Now, systemic signs like a fever, tachycardia, hypotension, altered mental status, think of sepsis. If you notice patients not feeling well, take their blood pressure. Make sure that they're not hypotensive. See how their mental status is. Don't just think, oh, they look a little weak, they're just a little under the weather. No, check the mental status, okay? Check for tachycardia. Take their temperature. Let's rule out sepsis, okay? Now, imaging. Imaging is always great, especially when it comes to acute on chronic on acute versus chronic. So, always image it, okay? But remember with x-rays, osteomyelitis lags about 2 weeks, right? But acute osteo. But if it's chronic osteo, you will see obvious destruction. Our MRI, our gold standard of imaging for osteo, detects the bone marrow edema early so you can see the early osteomyelitis. You can see abscess. You can see the sinus tract. This is critical on acute on chronic, okay, because it shows the new edema on old bone destruction. Perfecto. That's what we want. We want to see the map so we can know the surgical planning. Then bone biopsy confirms the diagnosis. Sometimes people just do the bone biopsy in the OR, brings the resected bone, sends it to pathology. That's what you're supposed to do whenever you remove tissue. Send it to pathology, let them test it, let them figure it out. And it helps guys the antibiotics get infectious disease. So, how would you trend osteomyelitic bone clinically? You have 5 domains. You have the wound itself, so measure the size, the depth, if there's any new necrosis, infection signs, check for erythema, drainage, your labs, your white blood cell count, CRP, ESR, okay? Imaging, no progression of bone destruction, or is there remineralization, things like that, okay? If you see that. And patient status, if there's no systemic signs. So, what is the body telling you? So let's say your CBC, you have elevated white count and left shift. Yeah, probably infection. Inflammatory markers, if there's an increase in ESRCAP. Remember we talked about procalcitonin helps confirm bacterial severity. Lactate. If our lactate is 2, we should be concerned. If it's greater than 4, equal to or greater than 4, there is critical hypoperfusion. We need to get vascular. We need to fix this right away. Okay, we gotta fix that. Glucose, if it's very high, I just associate high glucose with impaired neutrophils. Our soldiers are not working well. Okay, in my brain, I won't even say. So cultures, gotta take a deep culture, especially after debridement. Blood cultures, if you suspect systemic, but most likely they do that, especially if you're admitted into the hospital. Okay, now. Now, when it comes to seeing the invisible, if there is gas in the tissue, red flag, red flag, red flag, gas, red flag. Admit, NPO, figure out what's going on. Either get a CT, because if this is after the X-ray, get a CT or MRI, whichever you can get fast. See how far it's tracking, open incision drainage, or discuss surgical planning with the patient. Might be more than that. Bone erosion, like we said, our MRI will show early osteomyelitis, and then vascular imaging, API or Doppler, okay? Because ischemia may trigger acute on chronic, okay? And you have to remember, acute on chronic is actually an emergency. It's not like, oh, it woke up again. I mean, I have used that term like before. It woke up. So usually the patients start on antibiotics, usually Bank and Stosen. That's our go-to broad spectrum coverage because it covers like MRSA, gram negative, and anaerobes. Most likely, like I said, debridement, incision drainage, removal of all the necrotic tissue. If you delay it, there is a high risk of the tissue death and the infection to spread. Vascular consult, please. Always consult vascular. That's a really big thing. They will come down, okay? They will come, especially if it's urgent. Yeah, they will come. Offloading, immediate pressure removal, and glycemic control. So, how do we prevent acute on chronic deterioration? Because this is where you win clinically. Offloading. Offloading should be a non negotiable with any diabetic foot ulcer. Pressure equals reoccurrence. Debridement, removal of biofilm and necrotic tissue. Glycemic control. Remember, hyperglycemia equals immune paralysis, in my opinion. Vascular optimization, revascularize if ischemic. Treat the bone aggressively, antibiotics and surgical resection, and monitor closely. Catch early flares before it explodes. I like I said, patients need to be aware that if you keep the osteomyelitis bone in your body, you will have a flare, and the flares come back with vengeance. This is not about fear mongering. To be fully aware and do the right things that need to be done, because at the end of the day, this is all a decision that you have to make. To either keep it, do the bone resection, do the amputation, things like that. Okay. So, what does the research say overall? About 60% of diabetic foot ulcers become infected. Yes, osteomyelitis is a very common, very, very common complication and a strong indicator of amputation. Chronic ulcers are usually the main precursor. Recurrent infections are quite common, or approximately 27%, but I'm just going to round it up to 30. And the larger and the deeper the ulcer, the higher the risk of osteomyelitis. So let's do a case review really quick. 58-year-old male with diabetes, chronic ulcer for 4 months, stable, managed, no major complaints. Day one, slight increase in drainage. Day three, foot is swollen, malodor. Day five, fever, heart rate is 110, glucose is 310. Let's admit, labs, elevated white blood cell count, lactate is 3.2. Yeah, gotta admit. Get an MRI, shows deep plantar abscess, early osteomyelitis. What is the outcome? We're gonna have to do occupation menu and PO. You need a OR debridement, IV antibiotics, and limb salvage if possible, okay? But the alternate reality is the longer it is delayed, the higher the risk of amputation and worsening of the infection. So, what is the final takeaway? When you walk into a room, you ask, is this a chronic? This is a chronic wound. Duration, the depth, the recurrence. Is this a new acute changes, drainage, erythema, systemic signs? One thing I do see happen sometimes with acute on chronic, sometimes my patients will get reinfected, especially when I let them graduate to at home wound dressing, and they sometimes I don't know what happens, but it's just open to the non-sterile environment, so it might get infected with a new bacteria, and that could trigger it as well, okay? And I just do new world culture, and it'll be like a bacteria that I've never heard of before, or I can be able to tell if they're using tap water because there'll be something that's found in pipes. I was like, yeah, so use sterile water, okay? Sterile water, like the saline, okay? Saline, not some people respond better to sterile water, but I would use saline because remember it has sodium chloride, salt, right? A little bit of salt in that. Could there be bone involvement? If it probes the bone, high risk of osteomyelitis. Deeper the ulcer, the higher the risk. And is this acute on chronic osteomyelitis? If yes, escalate treatment immediately. Okay? So acute on chronic in a diabetic foot is not just a worsening wound, it's a tipping point where a smoldering infection becomes a limb threatening infection. So acute on chronic is not a complication, it's a turning point. Okay? So the wound didn't just suddenly get worse. It just finally revealed how bad it already was. And this is Diabetic Foot Files. This is Dr. G. And take care of your feet because they take care of you.